We're starting with our next session. Our next session is on the management of advanced laryngo and hypopharyngeal cancers. I would like to call upon the chairpersons, Dr. Gautam Makadia, Dr. Somesh Chandra, and Dr. Vishal Choksi. Dr. Somesh Chandra and Dr. Vishal Choksi. So we'll be starting with our lecture first by Dr. Satheesh CT. He's a consultant, medical and hemato-oncology, and director of clinical trials at HCG Cancer Center, Bengaluru.
Good evening, everyone. Thanks for the sponsor to give me opportunity to be here to share my little information about what is the concurrent chemotherapy beyond cisplatin. I'm going to talk about, not general head and neck cancer. We are restricted to the larynx and hypopharynx and laryngo-pharynx. And we know that we have heard about Dr. Anil sir, what is the role of neoadjuvant chemotherapy, CTRT and surgery. Sir was giving a clear, crisp idea about what are the indications. And we know the standard for going for radiation concurrent chemo, cisplatin. I'm not going because already this talk has already dealt by our previous speaker. I'm going to talk about what is beyond cisplatin. This is you can see this, this might be this kind of slides may be shown by earlier colleagues also. If you see that, we know that management is surgery, a radiation based, it can be a concurrent chemotherapy, sometimes sequential, sometimes we'll go induction chemo, then followed by concurrent chemotherapy. We know that standard treatment is cisplatin, but we know that it is not feasible for everyone when are going for a concurrent chemotherapy. There is we have to see alternative regimens, what we can do if this kind of patient comes in our practice. There are situations there, alternative cytotoxic drug can we choose, or we can go for biotherapy, or sometimes we want to do the better outcome, combining biotherapy to the concurrent chemotherapy. These various options are there. It can be post-surgery adjuvant therapy, or maybe definitely concurrent chemotherapy. Sometimes that sequential, that is a post-induction going for a concurrent chemotherapy. This this slide is showing this. We know that we have got a robust evidence. Concurrent chemotherapy is when you're going for radiation, your radiation-based treatment, you know that is a standard treatment when you're going for the treatment. I'm not going because already this talk has already dealt earlier. This is concurrent chemotherapy. When you're going, we are having various segments. That is a definitive CTRT, adjuvant chemoradiation, post-induction followed by sequential CTRT. When you're coming for a definitive chemotherapy, we are having option cisplatin. I'm not going in that already dealt earlier. Next, we want to do the best. Can we add something? Cisplatin along with adding biological. Is it any evidence is there? Can we do any better outcome in this situation? The next situation is cisplatin ineligibility. That is a practical challenge what we are day-to-day we are coming in our clinic. Next, that is adjuvant treatment. Post-surgery, we are having an idea we have to give a radiation. Sometimes we have to give the additional treatment along with the radiation. That is a adjuvant concurrent chemotherapy. Cisplatin is standard. Sometimes it's not feasible in every cases to give a cisplatin. What is the answer for the cisplatin ineligible patient? Next, post induction sequential therapy. There are various situations are is there in our day-to-day practice. Coming to we have to know that platinum suitable patient or unsuitable patient. This is the unmet need in platinum unsuitable patient. There are two segments are there here. One is definitely contraindication to use a cisplatin. Then other situation clinical scenario, they are a borderline patient. If you use a cisplatin treatment, definitely you will end up in a lot of complications, side effect. You might land up with a stopping both chemo radiation. That's what you then finally you're going with only RT when you're going for this kind of situation. This is the slide is showing defeating what is the cisplatin eligibility. You can see that green blocks is showing that okay is a green signal to going for a concurrent chemotherapy. The yellow is a borderline. The various clinical feature is there, age and renal function and peripheral neuropathy that we have to all audiometry assessment we have to do, and also cardiac function, all the things we should keep in our mind. And also previous treatment, all the things come in a picture. Complication rates are high post neoadjuvant or induction treatment when you're going for this, going for a cisplatin treatment. Next is definitely we are having a clinical scenario is a challenging is a contraindication for a cisplatin. This is we'll definitely will see that our Indian patient, diabetes, hypertensive, like elderly people, because habits old the habits they try to have a comorbidity with head and neck cancer, not feasible for surgery. We might go for a radiation that's not sufficient, but we are not able to give the cisplatin. What is the scenario? This how we can overcome this. This is like the beyond like the conventional chemo like cisplatin. What is the standard gold standard treatment so far we are having? Like that they wanted to have a better like outcome, adding biotherapy, that is a cetuximab adding to the concurrent chemotherapy, that is cisplatin based treatment. There are 3 trials are they failed. You can see that phase 3 data is there. There is no improvement in the PFS and overall survival rate. And there is the other phase 2 data is showing that even though response rate is there, but landing with a lot of complications, SAE, death. That's why this like the trial was stopped. And other one more like the concurrent chemotherapy adding cetuximab, there like you had a lot of complications when you're going with the cisplatin based treatment. That is like the radiation induced dermatitis, skin problem, mucositis. That's why like the cisplatin adding cetuximab is a challenge that is not practiced. Next, there other one molecule is anti-EGFR monoclonal antibody, that is nimotuzumab. This is one of the publication from Kidwai. That is the best trial. It is a phase 2 data. You can see there are 4 arm study was there. Like I'm going to concentrate on the 2 arm, that is a CTRT, that is cisplatin based treatment. That adding biotherapy, that is a cisplatin, radiation and nimotuzumab. Here you can see that even though phase 2 data, there is a clear cut that response rate was very high, and also median overall survival rate was at 60 months, it was not reached with the nimotuzumab arm, and almost 20 months, 22 months in the concurrent chemotherapy. What was it is in the phase 2 data. It is showing that we can be added as per this one of the phase 2 data, what is published from the best trial. Coming to the other like the phase 3 data from TMH, that is nimotuzumab along with the concurrent chemotherapy, like adding that like standard treatment, because they mainly studied in the oropharynx and all head and neck tumor also was taken. They defined into high risk category. Let us see that by adding this biotherapy, that is a nimotuzumab like along with the concurrent chemotherapy, can we have a better results? You can see here like left side, the primary endpoint was progression free survival rate. It was showing that by adding nimotuzumab like to the concurrent CTRT, definitely show the from 50% to like 62% increase in the response rate, while the progression free survival rate was more, and DFS also was more with adding the nimotuzumab. Next, second endpoint, that is like a local regional control, that is also more numerically, that is 57.6% to 67%. It is definitely is very significant, and also other second endpoint was overall survival rate also it is increment by adding in nimotuzumab to the conventional concurrent chemotherapy. But you should see that, but only drawback is only one single institution study. We have to have this multi-institutional study. We have to, many people are started practicing high risk head and neck cancer, like hypopharynx and like a laryngeal tumor high risk category. But we don't have a clear cut separate data for larynx, but this is one of the data available in high risk head and neck cancer. And they dissected into high risk category, that is a HPV negative, that is a general population what I presented a previous slide. It is HPV negative high risk category. You can see here like the primary endpoint median PFS was like CTRT was 13 months versus the 35.3 months by adding nimotuzumab. It is a statistical significant, and local regional control also it is very significant, some 17.3 months to 60 months. It was like it is definitely is very good improvement in the improvement in the local regional control with the percentage with adding nimotuzumab. Overall survival rate also from 19 months to almost showing the 36 months. And their updated analysis of nimotuzumab along with the concurrent chemotherapy, adding biotherapy, it has shown that 5-year like data overall survival rate you can see here. 74.7% versus that only conventional chemotherapy was 64.3, showing that is not only like early data, even 5-year data also is available, showing that can be addable, you can add in the high risk category. We want that, I want a better response to the conventional treatment, you can have that. But only thing, But multi-centric global study is not there. That is the only drawback to have a routine practice, but we can have this. Coming to the next clinical scenario is cisplatin ineligibility. We are having various cytotoxic drugs are there, biotherapies are there. We used to use like a carboplatin single agent clinically. Many doctors like oncologists they are practicing. Is it sufficient, or can we add carboplatin 5FU? Biotherapy cetuximab or nimetuzumab, like if it's not like feasible to go for cytotoxic, patient is not feasible to go for any cytotoxic drug. Next other drug is paclicarbo with chemotherapy, docetaxel with radiation. Then other one is a capecitabine, one of the older data also is available. Let us see that what are the data like individually. This is the one of the data from that phase 3 data, cetuximab, the radiation versus like cetuximab plus radiation. It is like you can see here, like is the loading dose followed by weekly, that maintenance like 250 mg per meter square was used. Primary endpoint was a local regional control. Second endpoint was a OS, PFS and safety data. You can see here clear cut. It is by adding biotherapy cetuximab has shown that the increment in that control, local regional control, that is a 24.4 versus the median control versus the 15 months. And 3-year control rate, you can see 47 versus 34%. Coming to this extended follow-up of this one, you can see here cetuximab along with the radiation definitely prolongs the survival rate. It offers almost a 45%, like 5-year survival rate is almost, you can see here 45% versus the 36%. You can see here median, like it is shown the improvement by adding a cetuximab. And the only drawback was radiation induced, like dermatitis was slightly more towards this, and skin problem. They are manageable with this data. Coming to the other combination, that is a carboplatin 5FU. There is a GOTEC study is there. There are two the protocols. One from the oropharyngeal tumor, and the other one is all like hypopharynx, oropharynx, and like larynx was involved. You can see here almost like 260, 226 patient in the GOTEC 1 study, and other one is GOTEC 2 is almost 840 patients were there. Here the dose they use a carboplatin 70 mg per meter square day 1 to day 4. 5FU was like 600 mg per meter square day 1 to day 4. Practically it's difficult to give in our routine practice 3 weekly, like along with the radiation. Shown definitely the improvement in the like compared to the RT alone. It's shown that median overall survival rate is almost 22.4% versus the 15.8% only radiation. GOTEC 2, it is also shown the increment in the overall survival rate, PFS benefit and overall survival rate. But added toxicity was one of the drawback, and administration of the drug during radiation, mucositis. These are challenges for us. We have to see that like, how it is practically we can use it. Next, the other protocol is there, paclicarbo. We are well versed with treating medical oncologists in the esophageal GE junction, cross trial, radiation and along with the paclicarbo. We are happy with the results before pre-operative regimen. But whatever the data in the head and neck cancer, it is a small study from the head and neck cancer, that 66 patient with this scenario. You can see here adding this paclicarbo, you can see the 2-year like a response rate, PFS and overall survival rate. You can see that 90%, 93 and almost 86% are the overall survival rate by end of the 2 years. But drawback is here is like the toxicity. The dose what they used here is not a routine conventional chemo what we use it. Here is a 40 mg per meter square, and carboplatin was AUC 1. But it's not easy. You can easily treat with esophageal cancer with a paclicarbo regimen in a head and neck cancer is very difficult. But it's one of the alternative options. Rather than going for only single agent carboplatin, can I go with this combination? This is one of the question for our oncologist. This combination can be used, but only thing is in a cisplatin ineligible patient. But you should monitor the toxicity and all the like manage the patient. You can able to do it. Next, this is a phase 3 data published in this year. You can the docetaxel along with the head and neck cancer like as a radiosensitizer in a JCO. That is one of the publication from TMH. You can see here they are definitely chemotherapy 7 mg with the docetaxel 15 mg per meter square. Next, adjuvant treatment also 6 weeks was given. This is like we had almost like more than 300 patient was included. Definitely CTRT versus even adjuvant also was used. Median follow-up of 32.4 months. 2-year DFS rate was 30% with the radiation alone, 42% for the chemoradiation with docetaxel arm. hazard ratio was significant, and median overall survival rate is 15.3 months with radiation alone, 25.5 months with the radiation with docetaxel. It is a very good thing, but challenging about the toxicity management. That is the overall survival rate what we have seen like is 41.7% with the radiation alone. Chemo radiation is 50.8%. Hazard ratio was significant, but was the major problem is the high incidence of toxicity, that is mucositis and with docetaxel armor, and also like the higher incidence of the like odonophagia and dysphagia. You can see here like grade 3, grade 5 toxicity was there, but you should manage. This all is done in a cisplatin ineligible patient. You can see here mucositis almost like 50% versus 22.2%, odonophagia is 52% versus the 33%. Conclusion, addition of docetaxel along with the radiation definitely improves the disease-free survival rate, overall survival rate in cisplatin ineligible head and neck cancer. It is a new standard of care, but how practically we are using, because most of the time we may not able to use it. Other protocol is a capecitabine versus cisplatin is available. It is can be used 500 mg like per meter square twice a day. It is appears to be comparable to the cisplatin incremental but added toxicity. This post-induction we are having a data for cetuximab and cisplatin, but challenge is about the post-induction treatment. Concurrent chemotherapy cisplatin is very challenging. Lot of discontinuation, mucositis, these are things you can see here right side. The results were equal, but here red one you can see here lot of hematological toxicity, discontinuation rate, all the things you can see with the cisplatin. Cetuximab can be manageable. The next other single arm post-induction treatment with the concurrent chemotherapy with the cetuximab. You can see here almost 3-year survival rate with adding a cetuximab is almost like a 69.5%. It is manageable with this, but post-induction concurrent chemo, we don't have like they have our data for cisplatin 3 weekly is there, but challenging lot of toxicity like following the induction treatment. There are biotherapy, like we don't have like cetuximab have a small data are there, but we don't have. This is one of the area we have to have explore in the new studies has to come. And that HPV negative and positive, like I'm not going in depth actually, because HPV negative they do bad, the short-term mortality in the HPV negative, and they try to have that adding a pembrolizumab along with the concurrent chemotherapy, but is not successful story. It is HPV positive, they have some increment in the like a slight beneficial, but HPV negative they don't do well with adding pembrolizumab. It is a negative study. Next, HPV negative high risk category, they added a nimtuzumab along with the concurrent chemotherapy is already previously I shown. It is shown the improvement in the median overall like PFS and locoregional control and even overall survival rate by adding nimtuzumab. HPV negative oropharyngeal cancer definitely shown the improvement in the PFS, locoregional control and overall survival rate by adding this drug. Definitely we have lot of unanswered the question like in the form of post-induction, which is the ideal agent in as a concurrent chemotherapy. Cisplatin definitely is there. We cannot use like in all the patient, toxicity management and poor tolerance is a major issue. Biological and you can have other alternative regimen, but we need more studies in this area. Adjuvant treatment, cisplatin definitely is a good answer, but cisplatin eligible, we don't have much data in the adjuvant setting. Carboplatin 5-FU, carboplatin along with like next is a 5-FU with docetaxel data is there. Because of lack of time I'm not showing here. I definitely I already shown the study. Conclude, we know that standard treatment concurrent chemotherapy is cisplatin, that to 3 weekly, but is not feasible in our Indian patient. Even weekly regimen also alternative regimen is there. Definitely we have a good multifactors are there to have a unsuitable for cisplatin based treatment. They are associated lot of toxicity. You should be very careful when you are using but any radiation alone. Can I use any other alternate regimen what I shown we can be used? That biological therapy cetuximab alone along with the radiation can be used, and also like carboplatin 5-FU or like docetaxel, paclitaxel. Like there's some of the patient like we can have a like not feasible for that, you can have a capecitabine. Previously the capecitabine is very difficult to use it, mucositis we cannot swallow, we cannot break the tablet. Now capecitabine is available in the dispersible tablet, now we can use it. then definitely that unanswered questions are there in concurrent chemotherapy in adjuvant setting, post-induction therapy following concurrent chemotherapy it need to be addressed with more trials are needed. Thank you.